with the panel. A lot of people still coming into the room, obviously. So we would welcome any of those questions that you all had asked or that anyone had asked. Feel free to grab the mic, come up to the stage, ask a question of our panel. We would love to see you and hear what you have to say. I mean, Karen's journey, your experience. Feel free to ask away. Okay, here we go. We got a question. Stana Basatova from the Czech Republic. Thank you, Karen, for sharing your story. I'm also the mom of a 13-year-old girl not treated well, looking for more ways on how to help my daughter and others in my country. I founded a patient organization, advocate for the Club for Patients, but honestly, I feel alone in the fight. I'm sure Karen or Maureen can identify and have something to share about that for sure.
Yeah, I'd like to invite Stella to email me because there's a group of parents around the world that work together on trying to help increase advocacy amongst parents and to support each other. We can share materials with you. I don't know, unfortunately, I don't have anything in your language, but your English seems pretty good, and we can even translate some of it. All of the stuff I've written is free to share for anybody who wants it, and as I said, it's in Hungarian because I met a Hungarian doctor who wanted to use the materials. So feel free to please, I don't know how to get in hold of you, but maybe through the webinar, you can just send me a private message with your email address, and then we can talk more about it. I know can be lonely, but yes, I do recognize you, Stella. Now that you say you wrote to me, I remember us having a discussion a while ago. So let's take it up again.
Awesome. We all need support for sure. My granddaughter, 2 months, has left clubfoot. The local pediatric ortho said her right foot is also MA. He chose not to do the tenotomy on the left foot because of good flexibility. Was this a bad decision, skipping the tenotomy? Will she pay a price for this later? Casey, that's a grand.
I was just typing a response to that.
Of course.
So I'll just say the response. I do have a handful of kids every year who have really good flexibility. Their ankles dorsiflexing 20 degrees. They typically are the kids who correct pretty quickly with just a few casts. So if the ankle already has the degree of flexibility that I'm hoping to gain after the tenotomy, I will sometimes skip that part, go into bar and shoes, but then I follow those kids even more closely than I do the ones who've had a tenotomy. And if there's any signs of recurrence, of not tolerating the bar and shoes, we'll revisit that decision.
And I think if I remember correctly, the research shows 10% of the cases don't end up needing a tenotomy for typical club.
Okay. Let's see. Questions coming in. Are there any tips for parents to ensure our child's case doesn't turn into a complex case, e.g. rocker bottom or etc. From Fiona G. Parent. Anyone that wants to chime in on that one?
I guess I can start it off that assuming that the child's foot was fully corrected through the casting process, then really adhering to the use of the orthosis, so the bar and boots or foot abduction orthosis. I'll talk about that later, but that's really a big thing to prevent relapses from happening.
Okay. I have a son with atypical club foot, one atypical club foot. How is an atypical club foot different, and is treatment different? That was from Jay Vega, another parent. Does anyone, Dr. Dobbs, you want to comment on that?
Yeah, I can take a stab at that. It's there's a bit of a semantics that goes on with atypical and complex, and you probably don't want to hear my diatribe on this, but complex clubfoot is different than atypical. Atypical is something you're born with. So, and that's often an underlying neurologic problem. As I kind of alluded to in the earlier talks, there's some kids that have less, robust muscle function or have congenital nerve, deficiencies that leave them weaker in that side. That's an atypical foot. A complex foot is often, one that we see occurring during treatment. So you may not be identified at birth. And so the classic features of a deep plantar crease, all these things you're going to read about, that's not present in most complex club feet at birth. This is something that develops during the casting process. And often it coincides with people slipping in cast. All these things sort of occur at once, and then the foot looks complex and it's diagnosed as a complex clubfoot. So sort of a chicken and egg scenario. What happened first? Was it complex at birth? Did it turn into complex with casting? What happened? So there's a whole lot of semantics around these two terms that are very, very confusing. The short answer is an atypical and complex foot require modified casting technique. Yeah, and they both require that same modified casting technique, though the outcome's quite different. Complex club feet, once you do the modified technique, do great. They're neurologically normal. You have to adjust where you rotate the brace and you do stretching exercise, but they do very well. They have no higher relapse risk than any other typical clubfoot. Atypical is much different. So you are going to be prone to relapse if that's truly the diagnosis because they're neurologic. They're deficient in some aspect of musculature and nerves that are required to maintain correction. So I know that's kind of a long-winded answer, but it's a complex question. Excuse the term.
Okay. Okay. Let's see. So I magged Helmi in actually we have Monir requesting the mic. We'll get to this question first. So the question is, what is the definition of relapse? When can I consider my child is relapsed and needs to revisit the process from the beginning? Anyone of the panelists want to?
Well, in the clinics, we tell the parents if your child starts to walk on the side of their foot, or if they start to walk a little bit on tiptoe, they can't stretch their foot upwards, then you've got to go back to the clinic. That's usually one of the first signs of usually it's the pointed toe, but it can also be the curved foot. Or the foot looks bean-shaped rather than a normal straight foot. Those are the things to look out for, I would say. I'm not a doctor, but that's just what we tell people in clinics when we're doing parent support.
Sure. All right.
So I think just to your part of that of when do we have to go back to the beginning, it would be uncommon for a recurrence to get to the degree that you would be back at cast number 1 for an infant, but you just have to go back as many steps to correct that part of the recurrent deformity and then sequentially stretch the foot back out. So that might be 2 casts, it might be 6 casts, but it really depends on the degree of the recurrence and what type of recurrence that is.
All right, so we just got Monir just came up to the stage. Go ahead, Monir.
Hello, can you hear me?
Yes.
Hi, that's me from again. Karen, I have a question to you. That you said that if my baby walks by toe, then we can say it's relapse. But my baby is walking normal. He is running, he's walking, and his leg is a little bit 62, now 30. He's bracing almost 12 to 14 hours. So how can I confirm as a parent that it's relapse? Because I found the left left leg is tendon is tight a little bit, but he's walking normally. How can I confirm that it's relapse? Because my doctor is not absent last for 3 months. And there's no special orthopedist over here in Chittagong who is working for Clubfoot. So I'm concerned a little bit. Can you how can I confirm that
I think
it's really relapsed?
I think as a parent, you can't really confirm the relapse, but you can look out for red flags of relapse. And I think the sooner you see them, the better to try and find help. Even if you send your doctor, there's a few stretches of the foot you can do to send photographs of this is how far if you put your hand underneath the child's foot and you push it so you can see how much dorsiflexion they have, how much does the heel stretch, or, maybe take a video of your child running. I used to do that with Dr. Ponsetti because I also wasn't sure. I mean, I think as a parent, you're forever staring at their feet, trying to see, if anything's different on them. And you can sometimes worry for nothing. So I think the best thing is to put your mind at rest, is to take some photographs, make a video, and send it to somebody to see, are they seeing the same thing as you? And then, like you say, it's far to go for treatment. Then you can make a decision. And also, just keep an eye of, is it still degenerating? Does it seem to be getting worse, or is it staying the same? Kids can sometimes look. They can sit and their feet are pointed in, and it's not always necessarily a relapse. I don't know if that helps at all. But
Karen, you were right. Karen, when I stress the right one, the correct one, and when I stress the left one a little bit tighter than right one, and it's too tight. So can I confirm that whether if it's not relapse, it can be relapse after a while, 1 month or 2 months?
Well, what's interesting is my son's foot started to have a tight Achilles tendon at the age of 14, and I thought that his tendon was tightening up, but actually what had happened was his foot had started to turn in slightly, and that was stopping him from pulling from the actual tendon from stretching. So I don't know if that makes sense without having a picture. And I was in Brazil with Dr. Nogueira, who's a very well-known doctor who deals with older children, and she explained exactly to me why, if your foot's pointing in a bit, you can't dorsiflex, you can't push the foot up. So even if the heel cord is tight, it doesn't necessarily always mean that it's the Achilles tendon. It might be the actual foot. So it's a complex question, and I don't think I'm qualified to answer except from a parent's perspective, which is what I'm giving you. But yeah, that's...
So one another question. Sorry to disturb all. I'm sorry. Does stressing work with this tight tendon? I mean, if I stress right now 3 times a day, is it work for lose the tendon rather than tenotomy? I don't want to go for tenotomy right now because here is no specialist in Chittagong. So stressing is okay for. I mean, can I check another 1 month by stressing leg for 3 times? And 14 hours BNB.
Yeah, if you can access a physiotherapist who can maybe check the stretch for you, that it's not a surgeon or a clubfoot clinic, and then perhaps also, I know Dr. Dobbs has published some exercises on his. He's got a resource for stretches you can do. I don't know if it'll help, but it's worth trying just to stretch it a bit. And yeah, it's difficult. Sorry, I can't really be of great help because I can't see what's going on with your child's foot. So, but that would be my go-to first thing would just go and check with a physiotherapist or somebody that you are, is it tightening up, and then try and find.
One last question. Sorry, one last question. So my baby is now almost 16 months old. He's walking, he's running, and he is very ecstatic. So if I go from fast, if it's relapsed, I feel, and if I go for tenotomy, if I go for casting, so he will feel mentally sick, or he will. I mean, the baby can mentally weak, or he can deprive. Can he feel deprived? You got my question, right?
Yeah, I don't think a baby, they might get frustrated, but I think it's part of, babies are incredibly flexible and resilient, and they, within a day or two of being in a cast, they find a way to move around regardless of the cast. So yeah, I don't think you have to worry about that. It's better to deal with it and actually get the cast on and get it sorted out than deal with something worse further down the line.
Monia,
Yes.
I have some very good contacts of specialists in Bangladesh that I work with very closely. I sent you a message on here, so if you check your messages, I've sent you my email address and I'll put you in touch.
that would be great. So I can send some videos as well as Karen or Mr. Matthew Dobbs. He is really helping us a lot. I sent some messages already, Matthew Dobbs. I talked already. He knows me in different ID. So thank you all, and thanks a lot. Thank you so much.
Thank you, Monir. Anybody else want to grab the mic and come up to the stage to ask their question? We would love to hear you in person. We had a question here. Is there an age limit where a tenotomy is not feasible? Whether we answered that one. And then the other question was, what percentage of children need a tendon transfer? Anyone want to chime in on that?
So for tendon transfer, in the literature, it's about 10 to 15%. I think in our practice, it seems to be about 7 to 10% of kids ultimately benefit from a tendon transfer. For a tenotomy, there's not a definite age limit, but you might change the technique in an older child. So rather than a full tenotomy like we do in infants, we might do an open procedure where we can lengthen with a bit more control in an older individual. But there's not a definite time limit.
Okay. We have another parent grabbing the mic. Bring her up to the stage.
Hello.
Hello.
Hi, I have a question. So, if for the length of the process for having the boots and bar for the years, does it differ from if the child was born with the mild, severe, or moderate clubfoot? Does it differ, or it's like almost like more than 3 or 4 years, or there is any difference between the mild and moderate or severe clubfoot? Did you got my question? What I'm asking?
Yes.
Hello.
We got the question. Yes, we did.
Okay, thank you.
Yeah. Dr. Dobbs, you want to chime in on that one? Or Dr. Shipman?
Sure, I'm happy to chime in. I think we addressed this, kind of earlier. There's, nobody can give you a recipe, exact recipe for duration of bracing that's going to work for every child. And it's really not, the classification systems, mild, moderate, and severe, they're not prognostic at all, so they're not helpful. I mean, if you're told your child has a, moderate clubfoot, what does that mean in terms of treatment? That doesn't change how I'm going to brace. Okay. It's not a difference in risk of relapse. It's more of a muscle function. And the classification systems that are out there, don't take that into account. So they're purely descriptive and they're not prognostic. And so, I wouldn't go on, if my child has mild clubfoot, I wear the brace for 1 year and I'm fine. It doesn't translate that way. So recommendations are still, if your child's tolerating things, try to get to the age of 4 is the kind of the gold standard right now.
Thank you.
Thank you. Coming up. Let's see. At 4.5 years, should the toes be rolled in, almost bent still? How about Karen?
This is not an easy question to answer. I think chubby kids often have weird toes. They've got funny little thin nails. The toes can look a bit weird and wonky. But I'd say by 4.5, no, I don't think the toes should be almost bent. I think it'd be a good idea to check that out and make sure there isn't something else going on. It also won't be very comfortable to wear shoes if your toes are almost bent and rolled in. I know that it took, I would say, almost until the age of 3 before my son's loose skin on the outside ankle and his toes looked like all other kids. It does take a while to settle into looking like a normal foot, some kids earlier and some kids later.
I think everything's very individualized, right?
Exactly. It's when we can't see pictures or see the child, it's not always easy. But so we can just talk in general terms about what we've seen before, and hopefully that.
Should a corrected club foot be corrected to a flat foot, or can there be an arch? How about Dr. Schifrin? I'll give that one to you.
Also a bit of a tough question, because I think kids without club feet sometimes have flat feet and sometimes have an arch. So, I see some club feet that are corrected and are more of the flat variety, but I also see some kids who have a bit more of what you would consider a typical arch. So I don't know that the lack or presence of a small arch or a flat foot is necessarily indicative of the final outcome of the foot correction.
Okay. Hope that covered that one, Lori. These are tough questions they're putting out to us. Here's a question from Dawn. Karen, what's your view on the increased stress on parents with increasing use of the internet, daily posting of a complex foot on Facebook, etc.? Parents have to take responsibility for finding a good doctor, and even now parents are offered more alternatives such as Botox and different types of bracing.
Yeah, I think this is very hard for new parents because there's so much, and often people who post those kind of things are a small percentage of people that are having problems, and the people that aren't having problems tend to not post on the internet. So you're getting quite a skewed view of what's going on out there. And I'm sure that Maureen can also, because she's on the front line of parent support groups, probably more so than me at the moment. I mean, we have one that I monitor for our South African parents, and it's actually quite a useful group because people don't post, they post interesting tips and ideas for each other rather than lots of complex club foot, because as a new parent, you have to understand that those are the exceptions and not the norm. And finding a good doctor, I think that is where sometimes support groups can be helpful if they're in your area, or you do your research. You could end up being with a doctor. We do have doctors in South Africa who maybe do 1 or 2 club feet a year. They don't turn the patients away, and those parents have to go somewhere else after a few months. They eventually contact us and say, it's not working, I don't know what to do. And then you find out this guy his last time he did a club foot was maybe 2 years ago. And that's really not. So try and find out, it's like any surgery or any procedure you're going to have, who does the most of those, and go to them, because they're the guys who are going to be the best at it.
Just to jump off on what Karen said, I think that as a new parent with a clubfoot child, it can be really scary to see all the different things that can happen. And like Karen said, I think a lot of people post when they are looking for solutions. They run into a problem and they're looking for somebody to give them some advice about that. And you just have to be really careful about what kind of recommendations you're taking from a Facebook page, right? You have to just be aware. I found it really useful because it kind of gave me an idea of what to look for. I was like, okay, I used it as a way to go, okay, these are all the things that I should be aware of. And then I kind of pulled back after that because I was like, I don't need to continue to be inundated with other potential problems that I haven't reached yet. So I think that Karen's right. If you can find the right support group, and just make sure that you're taking everything with a grain of salt, make sure that you're doing your research and that you're looking into it. But there's a lot of parents out there that are looking for support and advice. And I think the support groups can be really vital for that, but it can feel really intimidating to see all of the potential issues that people can run into.
Yeah, good, very good point, Maureen. I think, credibility and finding those credible resources, like something like we're doing right here, to get the information that you need is critical. And to look for those parents that you can bounce off of that are in your same, at your same level, treating, having similar situations, circumstances with their children, I think is critical. So, just taking advice off the internet is not always the best idea when it comes to these type of situations. So Fiona asked also, do you have problems getting your child to keep them on? I imagine the braces. I have a strong-willed 3-year-old who doesn't. And if you have a 3-year-old, they're likely strong-willed. And can't imagine the challenges that I have to keeping Boots and Bar on him. So wondering how tricky this might be down the line with their new baby. That's either geared toward Maureen or Maureen.
Yeah.
Yeah.
I've found that I actually have a very strong-willed 2.5-year-old who is extremely stubborn, but I have found that the most consistency I provide with putting on her Boots and Bar, the better outcomes I'm going to get. So we have really made sure that we've really adhered to the schedule. So it's been like whenever she's in her sleeping spot, she knows that the Boots and Bar are just part of it. We haven't ever missed a time. Thankfully, we haven't had any issues, any major blisters or pressure sores or anything like that. But I think for me, it's consistency. The more consistency you do up front, I promise you guys, it is going to pay out in the long term. When you get to be 3 and your 2.5-year-old is just like, hey, Mom, where's my Boots and Bar? I need to put it on. It just becomes part of their routine. So if you can set that up front, I think you'll really help prevent any struggles in the long term.
Awesome.
Yeah, I agree with you, Maureen. And I think when it's part of their bedtime routine, they do argue a bit now and then, like kids do when they don't want the car get in the car seat, or but it's not a major argument, and you can normally win those little battles. And I remember when my son stopped wearing his Boots and Bar at night, I had to put him in sandals for 3 nights because he was so used to sleeping in Boots and Bar that he felt insecure. He was like, that's part of my bedtime routine. So it is doable. And I think you don't ever stop a night because, and if you stop once because they're crying, then you've built yourself a bridge that's, is never going to, well, a burden that's never going to go away. So really consistency and being the parent and the adult in the situation in the room is always the best.
Very, very good. From Jason C. My son's 3 years old, corrected at birth, but one foot has underdeveloped calf muscle, and virtually no tibialis anterior. MRI of brain and spine negative. What pathway should he pursue now? Dr. Schifrin, Dr. Dobbs. Don't all jump up at once.
Was this a unilateral clubfoot? I missed the first part.
Yes. Well, he didn't say unilateral. Okay. He just said son is 3 years old, corrected at birth, but one foot is underdeveloped. So I would imagine unilateral.
Yeah, I mean, if you truly have no tibialis anterior tendons, you functionally have a drop foot. This is a bracing situation outside of a shoe and bar. This is a daytime bracing situation to maintain, things in the correct position along with physio. But that obviously needs a good physical exam. What tendons are working? Sometimes, you have one that's underdeveloped, but one that works. And you might have a tendon that works enough to transfer, to have a surgical procedure to give you better, ankle motion, active ankle motion. So it requires a good physical exam to give you treatment advice on that. But certainly therapy and bracing, if you've got a functional drop foot, is what you're going to need at a minimum.
Awesome. Are EMGs regularly used to figure out which muscles are active?
I don't routinely use EMGs in diagnosis because I think a lot of this you can determine based on a good physical examination. It's certainly a consideration, but it's not something that I've routinely used.
Okay. My 4-month-old daughter wears Boots and Bar 23/7 now, and her heel is raised, blisters by the boots. The wound is starting to discharge pus. I already added protection on her heel, but the situation didn't get better. Is there anything I can do to protect her heel?
I would actually recommend going back to your physician right away. That's not normal, and it's hard to say what's causing that. It could be that your daughter doesn't have the right range of motion, so she might not, if her toes don't come enough towards her nose and dorsiflexion, she may not be able to tolerate the position of the foot abduction orthosis or the boots and bar. And just the fact that it's a wound, it has pus, that all raises a red flag to go back and see your physician. And then my guess is your physician will also at some point recommend that you come back and see your orthotist to have some adjustments made to the brace.
And I can weigh in a little on that as well. I've seen a couple of questions about either a sore developing on the clubfoot side or a sore developing on the non-clubfoot side, which is honestly what I see more frequently. And why that is, I don't know if it's, the clubfoot has been casted and the other foot hasn't had as much stimulation. The shape of the foot, the heel position is a little bit different. But what I'll typically do if you have a sore on the non-clubfoot side that makes you unable to tolerate the boots is just cast the clubfoot side for a couple of weeks until the sore heals, and then make some adjustments and try again. If the foot is the clubfoot side and it still does have good flexibility, it's not an issue with relapse, then we work really closely with our orthotists with blister pads, adjusting some of the silicone on the boots, changing some of the plastic around the boots, changing kind of the angles that the boots are set at. So I think there's a whole lot of things, but the sooner that you can reconnect with us, the better, and the more you'll prevent from getting a really deep sore that'll take a lot longer to heal.
Exactly. I would think it has to. We got to get that fit right. Right? Okay. Some of these are answered. This is an interesting. Parent thwarted his 3-year-old efforts by securing the middle strap of the Ponseti boot with a zip tie nightly. I don't know about that, but what are your thoughts on that? Anybody?
I think as a parent, you try to find ways to keep your child in there, in their boots and bar, right? So one of our tricks is that we put her sleep sack on backwards so that she can't unzip it. And that's what we've kind of resorted to at the moment and seems to be working because she's not bothering it. But I do think parents try to find ways to keep their child in. So I always just recommend talking to your doctor about it. Send a message and say, hey, this is what we're struggling with. What do you recommend? See what they.
And similarly, I would actually recommend if you're working with an orthotist, and hopefully you are, to contact your orthotist, because there may be other things that we can do. There's all sorts of modifications. That's an advantage of working with an orthotist is we can do all sorts of things to help with the fit of the boots and bar, the foot abduction orthosis. So I'd really recommend contacting.
Yeah, I would suggest the same thing. Okay. Okay, we have Howie's coming up wants to request the mic. Bring you up to the stage. Howie, accept the mics. We'll see you in a minute. Let's see. Do you accept? Howie, you have to accept the mic. Once we accept you, you have to grab it. Let's see. Okay, well, that's delay. Grab it again. Let's see if we can do that. All right, here we go. Got it? Keeps requesting, so I'll see what I can do here. Giving it to you. I'm giving you the mic, Howie. Trying to get you on stage with us. Having a little issue on that end. All right, we'll go with the next question. Alice, my daughter is bilateral clubfoot and has been walking for several months, but does appear to be walking pigeon-toed. Is this a sign of relapse or likely to correct itself over time?
I was just
Oh, you just
your timing is perfect. So it's really common for young kids to into when they begin walking, and it can be a combination of rotation at the hips, through the thighs, through the tibia bones, or it can be a relapse. So without seeing your kid and their specific feet, it's hard to determine. But if they seem to have really good flexibility, if they're wearing their boots and bar and they're tolerating them really well, I don't know that I would be too concerned right now. And I would think it's more likely some physiologic developmental things that you're seeing on different parts of the leg and not necessarily the club foot.
If I can just jump in here as a parent, I think I can't tell you the amount of times that I've literally thought that my daughter that she was experiencing some sort of relapse, or every single time she stands on her toes, I'm like, is that something weird? I think that it's vital that you just are able to communicate with your clubfoot clinical team and just say, hey, this is what I'm experiencing. This is what I'm seeing, and bounce that idea back and forth with them, because I can't tell you the amount of times that Dr. Dobbs has said, no, it's good. You're okay. Because it's just very common, and I want to normalize that for parents. It's very common for you to be concerned and to be watching your child like a hawk. You guys have been going through this, and treatment is long. And so you can have questions throughout the whole way. And that's why I think it's just really important that if you find a team that you can talk to, whether it is the orthotist or the doctor or even a nurse, someone who's experienced that can help you, I think that it's vital in just having all of those little questions answered that come up, so frequently for us as parents. But it's really normal for you to look at your child's development and kind of question that every step of the way.
And as a provider, it's really helpful if you're noticing something with how your child is walking, take a video and send it to us or bring it in, because inevitably your child will not walk that way when they're in clinic. And so if it's something that you're seeing, bring videos, and it's really easy for us to look at those and get an idea of what you're seeing at home.
Absolutely. All right, so we're going to try this one more time with Howie and see if we can get him up here. Just grab the mic again. See if that works. Not sure what's happening on that end. So we'll hopefully he'll pop on. But Lori asked, finding a good PT has been proven difficult for us. What are the main things we should be looking for when finding a therapist? Does a physical therapist need to have specific experience treating clubfoot? Roz, that's a pretty good question for you, I think.
Yeah, sure. I would say it depends on what you're wanting to achieve with the physiotherapy. If it's a post-surgical, if they've had a tendon transfer, or if it's something specifically related to Ponseti treatment, then I would probably recommend that you try to find someone that has experience with clubfoot. We do, though, often in our clinics see patients that need more general physiotherapy, so generally strengthening the lower limbs or the core strength. And those things we might just write to the physiotherapist who doesn't specialize in clubfoot and ask them to work on those things. And I wouldn't think you need a clubfoot specialist for those.
Okay. Awesome. So just to clarify the previous zip tie comment, the zip tie was passed through the middle buckle and one hole punch of the strap to prevent unbuckling, not around the foot. So we modified the strapping to make sure that the child didn't rip it off at night. Mary Lou, can you describe the crawling pattern of a kiddo in boots and bar? Is it a reciprocal creeping pattern? Will there be any repercussion in the lumbosacral area with any wonky rotation because of the brace? Question. That can be for anybody that wants to chime in on that one. How about, I'll pick somebody. How about Maureen?
Yeah, so I'm not really sure about the specifics of the B&B and how you would like the crawling pattern. I just know that I think crawling that happened with my daughter and her B&B was always, I was never really concerned about it. So I don't know if that's the right answer or not, but as a parent, by the time she was crawling, honestly, she wasn't wearing them when she was really crawling. So it would be only on a really small occasion, because by that point she was really only wearing them during night and nap, because she didn't start crawling until she was about 9 months old. So I don't know if there's a really an extended reason why they'd be wearing their boots and bar while they were in a crawling phase.
Yeah, I would think, again, every kid's individual, right? Some kids crawl one way, some kids crawl a different way. So it's hard to really determine what's appropriate for your child, or put them into a certain box. Are there any brand of type of socks that would be best for the child to wear in their boots to prevent blisters? My daughter will be getting her boots and bar for the first time in 2 weeks. That's from Marcy. I think we answered that. Right?
Yeah, I answered this with a message. I know there's a brand of socks called Black Robin, which is designed specifically for wearing with a clubfoot brace. And really, you want a thin cotton sock that's got no ridges or stitching or toweling or anything on it. The less detail on the sock, the better. In fact, some of the cheapest socks are often the best because they're thin and they don't push down on the foot or cause. Sometimes an uncomfortable thick sock can cause a lot of problems in the brace. So it is an important question, actually, to talk about socks.
And I'll touch upon this again in the next session. But for the first couple days after the casts are removed, it's okay to use like 2 thin socks just for a couple days if their skin is really sensitive from being in the cast. But thereafter, you want to stick to just 1 thin sock per foot and avoid the thick socks with the grippers or anything like that, similar to what Karen.
Yeah, I think.
Sorry. I also just think it depends on your child. I think you just got to be prepared. We wanted one answer for what socks she should wear. And the truth is, it just depends on what you might have to buy a bunch of different types, and then just be prepared and try them out. And then when you find what works, it works.
Yeah. I would think you'd want something seamless as well, right? You don't want to have seams like, around the toe or around the, you want to have something that's seamless.
Yeah, I recommend that if there is a seam, that the socks are turned inside out, because what you see if there's a seam and it rubs on the toenails all the time, the toenails start to curl backwards. So if they have seams, I would go for turn them inside out.
Good. And I see Thomas also put in a link, so you can all feel free to check that link out as well. That's on the MD Orthopedics site, and MD Orthopedics is actually sponsoring this entire event as well. So definitely check them out. We'll be playing a short video in the next on the break as well. If I've had a baby with a clubfoot, what are the chances that it might happen to my future baby, my future children? Anybody, Dr. Dobbs, you want to chime in on that one?
Yeah, sure. There's no one answer for that either, because the genetics aren't really all worked out. We certainly know the more affected members you have in a family, the higher your risk is for a subsequent child. So this, if you've had one child with clubfoot, there's no other extended family history, your risk is higher than 1 in 1,000, but it's not real high. So you might half of it, 1 in 500. But if you've got 3 or 4 or 5 affected members through 3 or 4 generations, your risk is going to be, much greater. And so there's not a clear answer for you, but it really depends. And even families with, strong family histories, this is, in the genetic side of things, this is not a fully penetrant condition. So it skips generations. So even if it is genetic, you can have a whole generation without clubfoot at all. And so it's not going to appear in every child or even every generation. So there's not, unfortunately, I can't give you a direct answer, but.
Mm-hmm. Yeah, there was a comment actually in the last, I think it was the last panel, where there was a parent, the dad had clubfoot, the first son had clubfoot, but the second son didn't. And what would the likelihood of the third son having clubfoot? So, okay, so we're actually coming to a close. Howie, you tried again. I accepted you. I don't know why we can't get you onto the stage. Maybe in the next session we will. Actually, there's a short break between this session and Michelle's talk. So we're going to have a short 10-minute break. Thank you, everybody. If there's other questions, keep those questions. And believe me, we're going to be getting to a lot more as the next session comes to pass. So appreciate everybody, and we'll see you all in about 10 minutes or so.